I am from Cerrahpaşa Faculty of Medicine. My name is Hülya Çağla. I'll be talking about sleep disorders in teens and children. I've changed the order on my slides yesterday because it looked a bit dry, to be honest. I felt like I had to be a bit more focusing on the relationship of these sleep disorders with psychiatric factors. So I put those in the front of my presentation. Sleep disorders can be seen at all ages and in all parts of the society. They might emerge as a result of personal problems, financial problems, and they might also be leading to these problems as well. If sleep disorders exist, emotional and physical diseases become even more complicated. Berk is 5 months old. Berk's mom is quite tired and sad because she has to wake up a few times every night to console her crying baby. It takes a long time to go back to sleep. Berk is only 5 months old and he never slept through the night. When Berk was born, his mom thought and hoped that it would be an easy period because her first child was actually quite an easy child. She only had to wake up once a night, but that wasn't the case with Berk. What was the problem of Berk? The circadian rhythm, the balance between the daytime and nighttime, was not established. Of course, there are some natural references in circadian rhythm, like the awareness about daylight and nighttime, the changes in temperature, different clothing, change of nappies, primary caregivers, relationship with the baby. These are all natural references. However, we know that in the first 12 months, for such a rhythm to be established can be quite tricky. And of course, the nature of the baby is extremely important. And there are also some factors related to the mother. If the mother is over anxious, and if the lack of sleep becomes a problem in and out of itself. In the relationship between the mom and the child, the first 3 years is very important, and there are 3 important points of possible conflict. First one is toilet, the second one is food, and the third one is sleep. If these are points of conflict, unless and until these conflicts are removed or the problems are resolved, these continue to be adding to new problems to emerge. You can see this very clearly, but this is total sleep time as per age, different age groups. Starts from 16 hours for the newborns and of course comes down steadily into the teen years. During teen years or adolescence, of course, people think adolescents don't need as much sleep. However, the need for sleep actually continues. However, adolescents like sleep not as much. They don't think it's necessary. And the total sleep hours comes down to 7.5 hours during adolescence years. And it takes longer for adolescents to fall asleep. And of course, that makes it difficult for them to get up in the morning. Here is an adolescent. Umut is 16. He's been having problems falling asleep. By the time he finishes his homework and goes to bed, it's 11:30 p.m. And he has to wake up at 5:50 in the morning so that he can catch the service bus to school. He has to be on the bus at 6:30 because it takes a long time for him to go to school. When he shared this problem with his family said he's stressed about it, but he doesn't accept this because he thinks he can't fall asleep whether or not he's stressful or stressed about something. He just thinks that he's having problems falling asleep. And this continues to be an increasing problem. He loses his concentration, he can't focus in class, and he suffers or is concerned about his grades falling. Of course, the approach of the family is very important in situations like this. If you only tell the child that, oh, you're just stressed, it's going to be okay, and tell him off, it's not going to solve the problems. We need to understand the situation clearly and maybe ask help from a specialist. There are some factors that are influential in this whole picture: the parents' approach, attitudes, interaction with the surrounding environment, physical factors, emotional factors. For prevalence of sleep disorders in children and adolescents, as for the 1973 study, we see that 25% of the school children lack enough sleep, and 47% of school-age children in another study is found to be lacking sleep, and with sleep problems repeating at least 4 times on a weekly basis. When the patients arrive at the clinic, the parents normally think that they would make use of, maybe benefit from a wait and see approach, because when the problem is about children, it's thought by many people that it would pass. That's the general tendency. So they say, oh, shall we wait and see? And then we tell them, no, it's not going to help, because 60% of these cases will be chronic cases. So the relationship between sleep disorders and children and adolescent psychiatry, this could be a precursor of any psychiatric problems. There might be misunderstandings, misdiagnosis. There might be some psychological effects of lack of sleep or sleep disorders, or sleep problems might have certain effects on the family itself. So when we look at sleep disorders, relationship as per the nature of the child, these interrupted sleeps can be associated with anxiety and depression. As per Ryan and colleagues, 25% of depressive children suffer from hypersomnia, and these depressive children are mostly teenage people, and they are accused of not going to bed on time or oversleeping, but this blaming mostly happens for unnecessary reasons or not in a fair way.
In sleep disorder treatment and its effectiveness in depression treatment is shown by Neil and al. 20 hours of insomnia, then 24 hours of sleeping. When I was working in Germany, when it was actually, I saw that it was quite effective. After all this benzodiazepines, there was a female patient, and the clinical chief applied insomnia treatment on the female patient, and it was very effective. There is nighttime terror and nightmares are associated with the trauma, post-trauma. However, for traumatic children, there needs to be more studies. There could be psychosocial phonism, there could be bad childhood trauma, and there could be reverse effects with the childhood and childhood development. In 1982, Young et al. Made a study regarding this, and report showed that especially in severe OCD children, it reported that the children were suffering from lack of sleep. In Actually, depression, the sleep disorders is one of the diagnostic criteria of depression, somnolence, and also waking up late in the world. Insomnia is 75% more prevalent than hypersomnia. In insomnia, psychomotor agitation. In hypersomnia, the lack of appetite and also lack of hopelessness. In persistent sleep disorders, they would increase the risk of developing depression, and also insomnia are related with the increased thought of suicide. In depressed adolescents, there's increased sleep latency. And in some subjective cases, we cannot find the underlying cause with PCG. We cannot explain everything with technique. And BDT and antidepressants, they are more effective in treatment, in the treatment of sleep disorders. And when we consider anxiety, 90% of the children with anxiety disorder, there is a kind of sleep disorder. So it is actually two-dimensional, and they affect each other. And the early age sleep disorders are related with depression. However, the parents have less tendency to report sleepiness. In all these entities, depression, anxiety, the hyperactivity, and short attention deficit. Sometimes we may miss them. We do not question sleep disorder. And when we say he cannot sleep, we are so accustomed to this. Maybe we could say, let's add a neuroleptic so we can at this, so the social coherence compliance will be the same. However, sleep disorder is something that is a disorder that has to be questioned thoroughly. And in anxiety disorders, it is the same. I'm skipping this. Autism is important for us. In autistic patients, we have hard time treating the sleep disorders because the information we receive may be confusing. We have to get information from the parents, and we know they are challenged as well. In a meeting in Helsinki, the autistic child, they paid attention to the places of the beds, and they made a study. There was a device, polysomnography record was taken from the device. The bed should not be in the middle of the room, and taking the bed to the side wall actually is quite effective for the treatment of sleep disorders in autistic patients, because they have the three-dimensional perception is distorted in these children. When they feel more squeezed when the bed is on close to a side wall, and it is difficult to treat these patients. And when the daily problems are added, there could be rhythm disorder. The child can wake up at 2 in the morning and continue their stereotypical behaviors. And it starts on the 30th month, and it continues to adolescence. We need to pay a lot of attention to sleep hygiene in these children. For hyperactivity and short attention deficit disorder, it deteriorates the symptoms. The parents, they say that there is a hard time sleeping. They always talk about the nighttime terror. This is reported many times, and this could be an indicator of the daily problems. And also, while taking some corrective measures for sleepiness, we need to remember that insomnia increases the symptoms. When these sleep disorders are treated, we know that there are improvements in cognitive area. And in stores in 1992, in dyslexic trials, there was severe, persistent, and non-treated sleep disorders. So for the learning disability trials, we need to be thinking more medically, and we need to examine the sleep disorders in Klein-Levin syndrome. It is a rare hypersomnolence disorder. It affects the adolescents, and in 80 of the cases, it starts in the second phase. There could be some episodic disorders. We need to bear this in mind as well. There could be misunderstandings and misdiagnosis in children and adults. Parasomnias, as I have pointed out, the parents can think of a psychological reason. However, we say otherwise, because in obstructive apnea patients in adolescents, they could have some problems with sleep, and then it has to be examined as well. In Klein-Levin syndrome, the episodic behavioral syndromes can be named as the behavioral disorders, and if there are sleep disorders, the learning problems may worsen. An adolescent, if he's accustomed to 8 hours of sleep, if they are forced for 5 hours of sleep, they present aggression, depression, and agitation, and cognitive vigilance is decreased. The stimuli cannot be evaluated equally. The short attention, disorientation, hallucinations can be observed. The attitude of the family is important. The rituals in small children are important. Some rituals have to be exercised. They are important for giving the feeling of safety to child. And for sleep, it is an important reference point. And the interparental problems in my clinical practice, I observe the same thing. If there is a major partner problem, if there is a family-related problem among the parents, the children suffer from sleep disorder, insomnia. There was a 3-year-old patient of mine. She thought that when I am sleeping, my parents had a severe fight. That's why I don't want to sleep, because they will fight again, and I can't help them. This is an important point of evaluation. I always question this in the children with the parents. We need to question this in the first session, so we need to have a good part, and the detailed analysis is important in this regard, and the pathologies related to mother have adverse effects in sleep disorders. And there's the effect of sleep disorders on the family. The children with sleep disorders and learning these challenges, the mothers have less tolerance. They can experience problems. The physical punishments increase, and then the mother have the feeling of not being deficiency, and they could confront with depression. These are the things that I'd like to express. The things from now on are the things that are known by everybody. How much time do I have? When we classify the sleep disorders, there are insomnia, and there is excessive sleepiness, hypersomnia, and there are parasomnias. According to DSM-5, there is the main sleep and wakeness time. Insomnia, lack of sleep, or means lack of sleep, or lack of quality sleep. Hypersomnias sleep during daytime. There is narcolepsy, obstructive apnea syndrome, circadian rhythm disorders, parasomnia, non-living problems, and nighttime problems, and also the irritable leg syndrome. In insomnia, there is a problem going into deep sleepiness. It decreases the daily performance. In DSM-5, in the last 3 months, 3 bad nights experience are added to DSM-5, and in insomnia disorder is now used instead of primary insomnia. In pediatric prevalence, the pediatric, it's 1 to 6% of prevalence is there. And there is childhood age behavioral insomnia. This is because of the lack of limits of the family. For example, we just shake the people while the children or sleeping during watching TV. When the conditions are not met, the child can have hard time going into sleep back, and this causes the delayed. Let's say there's a 20-month of infant that at 2 o'clock in the morning, let's say that she wakes up and she just places her toys, and she does not want to be alone, and when nobody comes, nobody wakes up, she just goes up and goes to the bed of the parents, and the parents actually they take the child into their beds and they continue sleeping. However, in the upcoming ages, the child may not get accustomed to sleeping in her bed, so there should be as only one sleep friend. There shouldn't be many dolls, so that the sleep problems may not be experienced, so that the child understands this is the bed is used for sleeping, and it should pose a reference point. In the behavioral recommendations are the first options in treatment, and the family parents should be explained the things. Psychotraining is very important in this regard. In children, for controlled crying and gradual extinction is common. However, in school age, cognitive therapy and coping mechanisms might be better options. We have the types here since 6 months and 18 months. We know the Farber method. Farber is a very well-known researcher. It's a very didactic method. Sometimes parents cannot stand for crying. I do not support it very much because there could be, it may trigger some other mechanisms mentally. The children are fearful, then become fearful from the sleep, and the families refer again. There should be softer methods. There should be the methods that should be acceptable by the mother. There are behavioral techniques that could be applied. Of course, the parents and the cognitive level of the mother is very important, and there should be a very good connection to be established, because some psychologists, I have some psychologist friends, let's say for a month they're almost sleeping with the parents to correct the sleeping problem. It's the same. The medication treatment. This is something we rarely resort to, especially in small infants when there are crises. For a temporary period of time, very short time, it could be administered, but personally speaking, I don't use it. Only once or twice I most probably prescribed medications. Melatonin, it can be prescribed to autistic children, but I don't have a clinical experience. there could be, the parents could be informed for different coping mechanisms, somnolence and also rhythmic behavior disorders, and parasomnia. The nighttime terrors actually are feared for by the parents. They generally shoot a video of this, and it is like it might be very scary, but we say it's benign disorder and it can go away on itself. The British professor has a recommendation between 3 to 4 in the afternoon. There could be a half an hour sleep. It should not be more than half an hour, and it should then also waking up the child 10 minutes before that nighttime terror happens can be beneficial, and I have my clinical clinical experience in this. Somnambulous. This is the ambulation disorder. It has to be at least once, and of course when the patients they try to wake up, there's confusion. Their confusion deepens and they become disoriented. They could hurt, so their safety should be ensured very well. Nighttime terror, I have just pointed out, and some studies actually report a correlation between nighttime terror and anxiety. Of course, the cases should be addressed in depth. And what difference between the nighttime terror and also the nightmares? After the nightmares, the children wake up, they are conscious. In nighttime terror, there isn't repetition. However, nightmares, they could be repetitive. The nightmares actually are not that scary. However, nighttime terror actually are quite concerning for the families. Parasomnia, that is talking in the sleep, between 3 to 15 years of age. It is the prevalence is more than 50%. Psycho training and the safety measures should be taken. It's of utmost importance. There should be waking up diary and waking up before the episodes, taking naps during the days. It could be beneficial, as I have pointed out in my recommendation earlier. There could be obstructive apneas that could be missed in the children, respiratory apneas. The child is snoring, yes, there could be related to other medical problems, could be some narrowness, congenital narrowness, and these should be also addressed in medical terms. Between 2 to 8 years of age, it peaks actually. Polysomnography, of course, is conducted in sleep laboratories. Then, if there is respiratory problems, impulsivity, aggression, the behavioral problems, the executive function problems and performance decrease, and in the adults, again, there could be some dementia-like symptoms. There could be excessive tired exhaustion, and it could cause the loss of the job, so it should be addressed very well. CPAP treatment, as I pointed out, adenotoxinectomy and protection of irritant, and also the weight loss is important. Obesity is increased in the children, therefore obstructive sleep apneas increase as well. Okay, thank you for your kind attention.